Good evening, everyone, and thank you for joining us today. On behalf of NAARI Division of Jagsonpal Pharma, we welcome you all to this webinar organized by Haryana chapter of ISAR. We present to you Cystelia M formulated with ideal false 40:1 ratio of myoinositols and dechirioinositols to restore ovulations and reproductive health in women. We also have Cystelia 35, the dependable pill in PCOS. We also have Lycored M tablet, natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage to win the race, Lycored M contains two proprietary complexes, natural lycopenes versus lycobeads from Israel and L-carnitine and L-tartaric acid in a ratio of 2:1 to give highest available L-carnitine as Carnipure, which is sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link will be shared in your chat box for circulation. To refer this webinar in future, please visit our website, YouTube channel, Jagsonpal Medical Insights. Now I invite Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR, and Director Roots IVF at JJ Institute of Medical Sciences, Bahadurgarh, to please kindly initiate this session. Ma'am, over to you.
Yeah, thank you so much. Thank you. Thank you, Jagsonpal, Dr. Deepika, Mr. Ameet. And on behalf of ISAR Haryana, with our motive of Prayas Evam Vistar, we bring you this Inspire and Ignite series number 9. And today we are going to talk on stem cells. And with the blessings of our national president, Dr. Amit Patki sir and Secretary Dr. Asha Baxi ma'am, and with our team ISAR Haryana, Secretary Dr. Meenu Handa, Dr. Manju Dagar, and Dr. Laxmi Goel as the Treasurer, we bring to you this series on the stem cell today, where we'll be having two talks only. We will talk on thin endometrium, where I would give a brief overview of what all treatment we have for the thin endometrium, including the stem cells, the type of stem cells. And then we have a very, very eminent speaker today. We have requested Dr. Nayana Patel, who is a master in a name, who has been a pioneer in stem cells in India. So we are lucky to have Dr. Nayana Patel ma'am as the speaker for stem cells, and we'll have many new insights into what exactly are the therapies that are there, how they are effective, and her experience we will see, and the results that fantastic results that she is getting from from there. So just to introduce our second speaker, I think because then we will not waste time and there will be no interruption in between. So we have Dr. Nayana Patel is the Medical Director, Akansha Hospital Research Institute from Gujarat. She is a pioneer in the field of IVF and surrogacy in India. She had 1731 surrogate babies born at her center. She was the president of the Gujarat Obs and Gynae Society. She is founder president of the Gujarat chapter of ISAR, and she has authored many, many books. She has many research papers, and she has published and treated the world's first case of thin endometrium by bone marrow derived cell therapy in the CERM journal. She has also published first pilot study on the autologous bone marrow derived cell therapy for thin endometrium patients in the Journal of Regenerative Medicine. So we have a lot to look forward to. Before that, I would invite my first set of chairpersons, Dr. Rakhee Malhotra. She is Senior Vice President of Haryana ISAR. Welcome, Dr. Rakhee. We have Dr. Laxmi Goel, the Treasurer of ISAR Haryana. We have Dr. Pooja Bhayana. Dr. Pooja is from ISAR and a very active member of our Haryana ISAR. Then we have Dr. Neelima Chaudhary, from Faridabad ESI Hospital. And we have Dr. Neha Singh from Karnal Indira IVF. So for this first session, actually, we are both our MOCs, Dr. Manju and Dr. Meenu, since they were busy. I thought let's start. I only thought to introduce and start myself. And for this talk, I would be now starting my talk, and I would take the comment of my chairpersons at the end of the talk. So I would start the screen share.
So in the meantime, let me introduce my speaker. She is a dynamic and personality, a beauty with brain,
No,
and just
already
person.
introduced.
No, I would
Already.
like to add. I would like to add. So it's always good to hear her, and she has taken the Haryana chapters to
Okay.
new heights. So let's listen to her.
Thank you so much, Dr. Rakhee. Thank you. I know you are a great friend, and you always like to keep me pepped up. So we would talk on thin endometrium, the new advances in the treatment, and I have this everything. I've taken it from this Frontiers in Endocrinology 2024. So these are Wai Wang and et al. They have given from this. The whole talk is there. So we know the embryo implantation success depends on the embryo and the endometrial receptivity. And receptivity plays 2/3 of the role, and a good embryo plays 1/3 of the role. And a thin endometrium leads to lower implantation rates, increased obstetric complications, and adverse perinatal outcomes. In most cases, how do we say what is thin endometrium? We always do ultrasound measurement, and if it is less than 7 mm, we say it is a thin endometrium. But however, the definition of thin still varies. Some people consider less than 6 as the thin, and some consider less than 8. So there is still not a complete, well-defined sort of definition for a thin endometrium. But if we take an average, I think let's consider 7 mm as the thin endometrium. There are various causes. It could be iatrogenic, it could be a harsh DNC, a second trimester MTP, or it could be idiopathic, it could be poor vascularity, low estradiol values, or it could be inflammation, the chronic endometritis and the tuberculosis that normally we come across. Now, these are the treatments of thin endometrium. We would be talking on these, the drug therapies, and the endocrine part considering the estrogen growth hormone, HCG, GnRH analogs, and tamoxifen. Then about the drugs that increase the endometrial perfusion, aspirin, sildenafil, botulinum toxin, vitamin E's, and the stem cell. So we have the mesenchymal stem cell, the bone marrow derived MSCs, menstrual stem cells, adipose-derived stem cells and regenerative cells, umbilical cord MSCs, and endometrial MSCs. So we have these 5-6 type of MSCs that we have. And normally, mostly, we have been using the bone BMDs that Dr. Nayana ma'am would be talking of. Then we also have the human embryonic stem cells. Then this is something new. The extracellular vesicles and the exosomes are also there. And most of us have used GCSF and PRP. And also there are certain complementary and alternative therapies which some of us might have used. Now, talking about the drugs that we have, so we talk about the endocrine therapy, where we will briefly just touch upon all these 5 drugs that we have. Estrogen is the most important part to improve our endometrium. The main molecule that we have, and evidence-based treatment is to give a estrogen to improve the endometrium. How estrogen helps? It affects the dendritic cells, the B cells, the regulatory T cells, and improves the cytokines. These cytokines again cause the immune tolerance, improve the immune tolerance, and cause successful implantation. So we have various modes how we can give estrogen. We can give oral estrogen, we can give intravaginal, or we can use a transdermal route. Oral is very easy to use. We all have been using, but the only disadvantage is it has to go through the first pass metabolism. Intravaginal, there is the advantages. It doesn't have, there is no first pass metabolism, but the disadvantages: local irritation, discomfort, poor patient compliance. So transdermal estrogen, I was talking about, and but the difference, because of the skin difference, there could be a difference of absorption. Now, growth hormone also sometimes we use to improve the endometrium. And because there are receptors of growth hormone on the human endometrium, and this growth hormone will increase the endometrial blood perfusion and cause induction of the insulin-like growth factor, and thereby that is how it is active. HCG, we all understand, is a glycoprotein produced by trophoblast, and we have used it for triggering the ovulation. And we have the HCG receptors in the endometrium in the secretory phase, and HCG instilled in the cavity before embryo transfer can upregulate expression of these VEGF, LIF, and MMPs, and these cytokines improve the maternal fetal immune tolerance, increasing the endometrial thickness and improving the pregnancy outcomes. Then agonists also sometimes can be used. How they act is by their flare effect, they increase the estrogen levels and thereby stimulate the cytokines for the implantation and improve the thickness. Tamoxifen again is a selective estrogen receptor modulator. It has both anti-estrogenic and estrogen-like effects, and therefore some cases it acts by inhibiting the breast tumors where it is being used in those particular cases, and sometimes because of its estrogenic effect, it causes endometrial hyperplasia, and therefore in such cases where the endometrium is not growing, tamoxifen has been used. Then the drugs which cause increased blood perfusion, these are aspirin, sildenafil, botulinum, and vitamin E. Low-dose aspirin is a cyclooxygenase inhibitor, and it does not directly increase the thickness, but how it improves pregnancy outcome is by improving the morphology of the endometrium and improving the perfusion, and thereby improving the endometrial where the endometrium was not growing. There they had given low-dose aspirin, and it did not significantly increase the thickness, but it improved the pregnancy outcomes in those cases by improving the uterine and the ovarian blood flow. Sildenafil again is a phosphodiesterase type 5 inhibitor. It enhances the vasodilatory effect of nitric oxide on the vascular smooth muscles, and the NK cell activity is decreased after giving vaginal sildenafil, and thereby it improved the local immunological environment. Botulinum toxin A has been reported to improve the epithelialization, but there is currently insufficient basis for the clinical trials, and more clinical validation is needed. Vitamin E, a fat-soluble vitamin, and the hydrolytic product of vitamin E is tocopherol, and tocopherol as such is an antioxidant that limits the reactive oxygen species. Pentoxifylline is a methylxanthine derivative used in many vascular diseases. It again is an antioxidant, and there was this retrospective study of 143 patients where the thickness was less than 7 mm, and they had repeated implantation failures where the combination of both tocopherol, that means vitamin E, as well as pentoxifylline significantly improved the endometrial volume. Coming on to the stem cells and their derivatives. So we have these various types of stem cells. We have the totipotent, multipotent, pluripotent, and unipotent stem cells. So multipotent, we have the mesenchymal stem cells, which we mostly talk of, and they have a high self-renewal capacity, and they have a multi-lineage differential potential. And we have the various, depending on where we are getting these stem cells. If we are getting it from bone marrow, we call it bone marrow derived MSCs. If we obtain it from subcutaneous adipose tissues, like from human thigh or abdominal wall, it is known as the adipose derived stem cell. If obtained from the menstruation tissue, it is called menstrual derived stem cells. And if obtained from umbilical cord, it is called umbilical cord mesenchymal stem cell. Or from the endometrium, then it is called the endometrial mesenchymal stem cells. And the embryonic stem cells are from the pluripotent stem cell category. So coming on to the bone marrow derived stem cell, the Cervello et al., he found that bone marrow derived stem cells, they accumulated around the small blood vessels in the injured endometrium, and through the paracrine, their means of acting, they upregulated the platelet responsive protein and downregulated the IGF, ultimately leading on to the proliferation of the epithelial glandular cells and causing thickening. But the limitation is that you need to do a bone marrow biopsy, which is an invasive procedure. Then subsequently, you have to do the cell sorting. Interventional radiation is needed. Sometimes when ma'am will be showing that when we have to put the catheter into those small uterine arteries, it does need an interventional radiologist and the whole setup of interventional radiology. And therefore, sometimes it is a little expensive and harmful. Now, adipose-derived stem cells, they can be obtained and isolated from the subcutaneous adipose tissue, from the human thigh or the abdominal wall. They have ability of multidirectional differentiation. They are easy to obtain, have high proliferative activity, and the endometrial adipose-derived stromal vascular friction is obtained by enzyme preparations and centrifugation that contains the adipose-derived mesenchymal stem cells, the adipose stromal vasculature, and many other components. And despite the cosmetic effects of liposuction, the overall cost of this whole treatment is quite high. The menstrual stem cells also stimulate the invasion and proliferation of these EECs and regulate cytokines. And recently, the researchers have converted the menstrual stem cells into decidualized stromal cells, which are more secretory. And these DSCs promote the restoration of the endometrial thickness and contribute to the production of the endometrial glands and the blood vessels. And they can be derived from the individual's own menstruation tissue. And clinical application scenarios are worthy of further study because we are taking it from the own menstrual tissue, so it is not an expensive thing, and more people are doing further research on these menstrual stem cells. Now, the umbilical cord stem cells are derived from the discarded neonatal umbilical cord tissue, which are easy to culture. They have, again, multidirectional differentiation, low immunogenicity, short proliferation cycle, long survival time. And they have been shown to restore the thickness by promoting the blood vessel growth, the endothelial cell proliferation, and down-regulating the pro-inflammatory factors and up-regulating the anti-inflammatory factors. But because of its allogenic origin, their application still remains little controversial. Endometrial MSCs are again multipotent, and they have the ability to differentiate into fat, bone, cartilage, skeletal muscles, and smooth muscles. Human embryonic stem cells, they are a class of pluripotent cell, and they originate from the cell mass within the blastocyst during embryonic development. But there is a risk of immune rejection, and there are other ethical issues which still need to be considered. Extracellular vesicles and exosomes. Now, what are they? EVs, or the extracellular vesicles, they are membrane-bound vesicles. They are found in biological fluids, and they carry and transfer the regulatory molecules like microRNA and proteins, and they play an important role in the stem cell support, tissue repair, and immune regulation. So we have these three types depending on their size. Exo are very small, and they have a diameter of 40 to 60 nanometers. And they, depending on their origin, they are divided into these three categories. They originate from the multivesicular body. Microvesicles are 100 to 1000 nanometers, and they are formed by the detachment of the cell membranes. Apoptotic bodies, there are 1 to 5 mm. They are bubble shaped, and they are formed by the collapse of cell membrane during the programmed cell death, containing the DNA material and the organelles. Now, these exo from the adipose MSCs, they can improve the thickness and the glands, umbilical cord. So all these, whether they are from adipose tissue or from the umbilical cord or from the bone marrow derived, stem cell derived exo, or from the amniotic, all of them actually are improving the endometrial thickness, causing endometrial angiogenesis and the differentiation. And engineering methods, now they are combining these mesenchymal stem cell exo with a collagen scaffold to form a load, and thereby these exos are then gradually slowly released at the corresponding site and keep exerting their effects at later on. But we have a lot of limitations. With the stem cell therapy, we have the immune problems, ethical issues, tumorigenicity, low retention rate at the transplant site caused by the shape of the uterus. GCSF infusion, GCSF, a glycoprotein involved in the follicular growth and development, has a bidirectional regulatory role in the maternal embryonic exchange. And actually, this was the first study was done by Gleischer, where he had those cases that were resistant or refractory to estrogen and the vasodilator therapy. In them, he used this, and all these 4 cases, they became pregnant. So that was I think, a breakthrough when the GCSF started coming into practice, and later it has been utilized still. And Lian et al, they in 271 cases, they could significantly increase the thickness by using GCSF. PRP, again, a very, very commonly used mode of treatment these days, and the how we prepare it and all, I think ma'am will give us a insight into that. But these days now, what it exactly is, PRP is platelet rich plasma, and we have now the second generation PRP which has come. And it has a different proportion of the cellular components and a different fibrin architecture, which is richer in fibrinogen, has a longer lasting effect. And PRP has been used a lot in plastic surgery, in sports injury cases and all, in hair regrowth, skin grafting, dermatology. And it can be used by either injecting it into the endometrium through an endoscope, through the hysteroscopic control, or it could be even just used as a perfusion through a uterine catheter, like we do a IUI. And the number of injections varies from 1 to 3 with the time spacing. And many cohort studies have used it, and they have seen an effective improvement of the thickness and the improvement in the clinical pregnancy rates and reduced cycle cancellation rates. How it acts? It causes increase in various growth factors like VEGF, PDGF, EGF, tumor growth factor, IGF, and many other cytokines are released by the platelet activation at the site of injury or inflammation. And one of this VEGF is responsible for the vascularization. And by this causes proliferation of the endometrial cells and increases the endometrial mesenchymal stem cells and increases the thickness. We have various complementary therapies Jin Feng Wen, Ding Kun Dan, some very, fanciful names. Some kidney tonic, blood boosting tonic is EV, a combination of all these, acupuncture, and all of them, how they are working is by altering this signaling pathway, modulating this by down regulating the AMPK and by up regulating the mTOR gene expression. And another is also pelvic massage, which in some cases they have tried by to improve the endometrial thickness. So these are few of the complementary therapies that we have. So just a brief, whatever I've just said, estradiol viral rate, how it increases by thickness, by different routes can be used, and it again improves the clinical pregnancy and the embryo transfer rates. Growth hormone, simultaneous administration of the growth hormone and HRT has been used, and it can cause a more targeted effect, and has even meta-analysis have shown that adjuvant growth hormone can increase the rates. HCG, GnRH analogs, tamoxifen, all of these improve the thickness, but more studies are needed. Low-dose aspirin promotes the growth and repair of the intima, reduces the thrombosis. Sildenafil again improves thickness. Botulinum, vitamin E, all improve the thickness and the receptivity. And again, all these bone marrow stem cells again have repair the endometrium. Most of them thicken the endometrium. So these are all again the same thing what I have briefed. They have been tabulated here. So the 2019 the guidelines on the thin endometrium, what do they say? That in the thin endometrium we suggest against the use of aspirin. So these are the 2019 guidelines. I could not get any guidelines more recent than this, but these ones do not promote the use of aspirin. And in patients with thin endometrium, they suggest against the use of luteal estradiol to improve the pregnancy rates. Then in patients with thin endometrium undergoing embryo transfer, there is insufficient evidence to recommend the use of sildenafil to improve the pregnancy. And again, against the use of intrauterine infusion of GCSF, and also against the use of pentoxifylline, HCG, gonadotropin-releasing hormone agonist, platelet-rich plasma, or stem cells to improve the pregnancy rate. So avoiding unnecessary uterine operations should be done so that medically the iatrogenic reasons are taken care of. And we have various, they can be by clinical measures ranging from hormones, medications, and regenerative medicines to promote proliferation. Traditional alternative therapies and adjuvant therapies can be tried. When the effect of single treatment is inadequate, we can use multiple treatments, but more large sample clinical studies with designs are needed to investigate these molecular mechanisms. So with that, I thank you all, and over to the chairpersons for their comments.
Dr. Jyoti, as usual, very beautifully summarize everything, each and every from very basics to advanced treatment, and explain beautifully about how they act, about the thin endometrium. And we were thank you so much for that nice lecture. But I have two questions for you. First is, do you have any experience of increasing the endometrial thickness with arginine?
We do use arginine. Actually, in this, yes, we do use, we have been using arginine a lot.
Yeah. And yes. Second is, in general practice, what do you think you must be in touch with all other colleagues also, your friends also, and sitting here, other chairpersons and audience. I want to know what is the most commonly used for thin endometrium, what you use in your practice. Not everyone is using stem cells.
Yes. So see, we are using, I don't know, the evidence says the aspirin does, we use aspirin, we use vitamin E, we use arginine, we use PRP, and we use sildenafil. So all
So what, all this you're using, but how you choose the patient that in this way I will use sildenafil, in this I will use it, or you go one by one. If this is not working, the same patient you go. But how do you go forward? A patient has come and you have seen the thin endometrium. Now what next? So what steps? How will you go forward to treat her? Basically, how you decide this? If this I have to use this thing. If you're using everything, then you have to decide that in this patient I have to use this.
See, Dr. Rakhee, actually vitamin E and aspirin with estrogen I'm using for all, because as it is, vitamin E does not have any harmful effect, and aspirin also we are using for a very limited period, though they say it has been told that it does not improve the thickness but improves the blood flow. Then if these are the three things that basically I write for all the patients, wherever I feel the endometrium is around 7 and I want to make it to 8, 9, so I use these three. But if still it is not increased, then maybe we just in the next cycle we use the PRP as well as sildenafil.
And in that cycle, you go ahead with that only treatment. You go with the or
yeah,
you cancel.
see, it
No.
all depends. If you do, if you are doing a FET, then you might as well do it in the next cycle. I might not do it in this particular cycle. No?
Yes.
So you can. It is because doing a embryo transfer is in your own hands. You can take more time and get once you yourself feel confident that now my endometrium looks good and has a good blood flow, the Dopplers are good, then only sometimes actually as it is, I think we will, since in this discussion we will keep waiting Dr. Nayana, and she has a beautiful talk. So I think after her talk we will discuss with ma'am.
Okay. Thank
Yeah,
you, Dr. Jyoti. Thank you so much.
yeah.
One thing I would like to add,
Yeah. Who, Dr. Laxmi?
Dr. Pooja, ma'am.
Dr. Pooja, okay. Yeah, Dr. Pooja.
Ma'am, one thing I would like to add, I think there is so many people. Just a minute, ma'am. One thing I would like to add is a good hysteroscopy done in a patient who is having thin endometrium actually works. Rest all, I think, are cocktail therapies that we try in vain to increase the endometrial thickness. So,
Absolutely.
for me, the first line of action is a hysteroscopy and then proceed. उसके बाद तो मैम सब cocktail हैं, whichever works, you keep on giving. And the best thing is that even patients with thin endometrium do get pregnant after the transfers. You just need to explain to the patient the chances of pregnancy will be lower in your endometrium, but then it is not never zero.
Yes.
So in case the patient is willing, we can always proceed with the transfer in thin endometrium also.
See, we have got pregnancies even in endometrium as low as 5 mm also, 6 mm also.
Right, ma'am.
So it is not absolutely mandatory that if it is not growing anyhow, if we have done everything, we've done hysteroscopy, we've ruled out chronic endometritis, we've given her a good course of antibiotics, everything we've tried, and if it is around 6, 7, we do have to do the embryo transfer. But you are very right. The hysteroscopy has to be done to rule out why it is thin, maybe, but that is the first thing, along with all these cocktail to improve the blood flow and to improve the thickness and all. Yeah.
Right.
Thank you.
Yes, Dr. Jyoti,
Pharma-
I think it was a very good talk, and
Yes,
matlab you have covered everything, and we are also eager to hear from Dr. Nayana ma'am, because stem cell is something which we are not used to and which we are not using, and you have highlighted very well all the modalities, and I think the next thing to use is the stem cell, which we are still in line to use that.
Yes.
So
Yeah. Thank you so much, Dr. Laxmi. Dr. Neha, your comment, please.
Yes, ma'am. Regarding the hysteroscopy, I want to add that we cannot offer hysteroscopy in every patient. First, we have to try these modalities of treatment. And if the endo is not getting better, then we have to go for hysteroscopy if there is no other factor.
Okay. Dr. Neelima, are you there? If you are there, then we take your comment. Otherwise, we move on. We have Dr. Nayana waiting there to give us another beautiful insight onto the stem cells.
And we are also waiting for ma'am too.
Yeah. So, okay. So we again, thank you so much, the chairpersons, for your comments and for your presence. Now we move on to our second speaker. I've already introduced you, ma'am. And I would like to invite the chairpersons for this. The chairperson for this session are Dr. Poonam Loomba. Dr. Poonam is our founder, member of ISAR Haryana, the senior, and she has been the treasurer of National ISAR as well. Sorry, the librarian of National ISAR. Then we have Dr. Manju Khurana, our past president ISAR Haryana. Dr. Renu, Chugh, I think, was traveling, so she may not be able to join. She was also the past president ISAR Haryana. Dr. Gurneesh Singh is the president of Hisar Obs and Gynae Society. Welcome, Dr. Gurneesh. And Dr. Anurag Vishnu is a very, very senior practitioner practicing IVF and a great embryologist himself from Hisar. So welcome all the chairpersons, and we would invite our speaker now, and we would take your comments after ma'am's talk. So, Dr. Nayana Patel, ma'am, I've introduced you, I think, because before you were logged in, I suppose. So, since all our audiences know about you, we would now like you to throw a light on stem cells, and I request you to talk more on the practical, how you prepare PRP, how you prepare the bone marrow stem cells, and how exactly, more of practical insights, additions also from your experiences, we would like to know. Thank you so much, and over to you.
So I pay my tribute to late Dr. Shankar Narayan, who has taught me the stem cell treatment for infertility. I've added a little bit of PRP also over here. And I'm just starting this talk because this message was in October when a lady from USA had contacted me in March 2024, 41 years, 14 years, primary infertility, married life, AMH 0.151. She requested for ovarian rejuvenation, which I counseled her that it is experimental and her age is not by her side. All said and done, she wanted to do it. So we did the bone marrow derived stem cell therapy in July 2024. Post that, she went back to America. And in 3 months later, we always ask for their hormonal reports and scan reports. She messaged that now instead of 5, I have 9 follicles. My FSH, which was 21 in March, has dropped to 8.8 in October. And also the AMH has increased from 0.151 to 0.696. And this is regarding the endometrium. This 37-year-old lady had 2 ectopics, 3 IVF, 8 times endometrial embryo transfer, all negative. Multiple leprohistro was done with Asherman syndrome removal, even myomectomy. And she had frozen embryos at another clinic and was advised surrogacy because her endometrium was thin. And that was the time when surrogacy was virtually not started, and even now it's very difficult. So he advised her for a hysteroscopy and then stem cells into the uterine artery spiral arterioles. She agreed. We did that in November. In January, we could manage to see that her lining was 7.5. We sent her back to the center where her embryos were frozen. Transfer was done and a healthy baby was delivered in August 24. So is this the time to rejuvenate ovaries and endometrium? I think yes. Regeneration means that you try to replace the lost specialized tissue by proliferation of undamaged specialized cells. It could be PRP, stem cells, and exomes, which Jyoti has explained very well. But platelet-rich plasma, all of us are doing. Somebody is happy with it. Somebody says, no, it's no result. It's not giving any good results. But we have to do the proper technique for the correct patient and decide how you do it. So definitely it helps because it's helping in all other branches, if you see in medicine, because it releases growth factors. And then these are attracted by the tissue injury to the local site. And when they go there, they intensify the body's healing effect. Procedure we know, the first spin, second spin, but the most important is the selection of the patient. There should not be any hematological disorder. We should count the platelet once it is done. So that I'll tell you a paper which is very, very good in that quality of PRP, what you are using. How does it act? It has an anabolic effect through the growth factors, then an anti-inflammatory effect because it has inflammatory mediators, and also a scaffolding effect because of the fibrinogen. And this is a paper which tells you about the product, what you are using as PRP, and what is the quality control. We should know the pre-platelet and the post-platelet count, and that is when you don't dilute it. When you have that buffy layer after the 2 centrifugations, take a drop from it, and it should be 3, 4, 5 times than the original. If it was 2.5 lakhs, it should go to 8.59 lakhs. There should be least contamination. And most importantly, the activation part is very, very important, how you activate it. Because when you are going to inject and you just inject it like that with the activation happening 1 hour before, or it has been prepared in another lab, the potency of the stem cells, the PRP will go, because there are granules of platelet-rich plasma, and after activation, they break, and within 15 minutes to 45 minutes, all these growth factors are released. So that is the time when you need to inject the PRP wherever you want, in the ovary or in the endometrium or subendometrial PRP. When we culture the mesenchymal stem cells in the PRP, platelet-rich plasma, so whenever the bone marrow is getting ready, and after that, before we inject, we place it in the platelet-rich plasma also. That also amplifies the effect of stem cells. So this is the procedure, which I'm not going into the detail. Then there are various publications which are there for platelet-rich plasma. Stem cells, yes, it is making a difference and revolutionizing the healthcare. You can see the potential uses, and now the reproductive medicine can also be a part of it. Stem cells have become promising because they have a specific characteristic of multidirectional differentiation, angiogenesis, immune regulation, and parakine stimulation. Again, when there is an injured tissue and you give the stem cells, you can give it IV, you can give it locally into the same organ, and locally giving in the same organ is good. Or you can give it to a vessel where it goes to this organ. There are 3-4 methodologies by which you can instill the stem cells. There it will be attracted by the injured tissue, that what is known as homing in of the stem cells. It will get integrated with those somatic stem cells with non-tumorogenic properties. Like, for example, in the granulosa cells, it will participate in follicle development and regulate ovarian physiology, including ovulation and luteal regression. It can reside in the reproductive tissue and ameliorate the damaged environment. And it is also said it can restore the endocrine function by secreting anti-inflammatory factors and increasing the Treg population. There are various types of stem cells, but we go for the multipotent adult stem cells because totipotent could be tumorogenic, pluripotent may be tumorogenic, and multipotent is where we are safe because it has got limited tumorogenicity and immunogenicity. What we use is the bone marrow, but adipose tissue can be used. Umbilical cord is another good source, and menstrual blood also can be used. The advantages of mesenchymal stem cells that there is no ethical concern because you are using from the patient herself. There is limited immunomodulatory function, very low immunogenicity, and chemotaxis. So how do you do? Whenever you take a patient for stem cell therapy, you have to give a proper counseling where has to be some recording of it that it is an experimental procedure. Though you can show that so many publications are there from all over the world, wherever it is. Once they agree, after the audiovisual consent, you start the pre-procedure workup like any other procedure, call nil by mouth, give at least oxygen for 2 to 4 liters for 30 minutes, and antibiotic, vitamin C IV, and glutathione also IV. This is all because we want to give a lot of antioxidants and get the best cohort of the cells, stem cells that we are going to extract from the anterior iliac crest. So once this is given, and when the patient gets admitted, we also collect 30 to 40 ml of blood for preparing the platelet-rich plasma. As I said, we culture the stem cells also there, and we can also inject directly stem cells mixed with platelet-rich plasma in the ovary or in the uterus or in the femoral artery. So we do this under anesthesia because it is quite a wide bore needle where you extract the stem cells from the iliac crest. There are simple needles available where you can do it from the tibia, but the amount of bone marrow concentrate that you need is a good amount of at least 50 ml. 60, 80 is very good, but minimum 50 should be there to get a good cohort of bone marrow derived concentrate and then get the mesenchymal cells separated. We use the automated machines which are available. There is a special bag for it in which you collect. There they say at least 80 ml should be collected, but even with 50 it works. And then you put it in the processing unit when automatically the mesenchymal cells will be separated. Once it is done, you have to do the quality control. Each stem cell, will drop of it, you have to store it wherever you have used it for which patient. Do the infectious disease profile again on the stem cells that you have collected. And you have to also put it in a culture dish, though you use it immediately, but you check for any growth or contamination the next day. This is the stem cell lab, and these are this biomarkers, the CD4, 34, 73, 90, 105 cannot be done immediately. So we just count the mesenchymal stem cells, and on an average, it is said that 1 million per kilogram body weight is the ideal that you should be injecting. Now, in the female infertility, mainly we use the stem cells for ovary and for the endometrium. The role of this PRP or stem cells in ovary is not limited to primary ovarian insufficiency or diminished ovarian reserve. Even when you have failed fertilization and the embryologist says that the egg is not good quality, there are recurrent miscarriages due to low AMH and no other reason for miscarriage. Then low success rate of fertility treatment, reversal of menopause also, and in cases of PCO and endometriosis also you can use it. We all used to believe that there is a fixed primordial pool for so many years. But now with the successful discovery, isolation, and establishment of ovarian stem cells, we have got a hope that this fixed pool is there, but definitely there are oogonias or oocyte stem cells available in the ovary in the cortex. So if you see this schematic representation, you can see that in the cortex, there are the oogonia or the ovarian stem cells located. So what will this do rejuvenation with stem cells? It will create new ova, not create as such, but activate the ovas which are there, could develop competent oocytes, and it can also restore the fertility and at the same time alleviate some of the side effects associated with low estrogen. So the menopausal symptoms can also get better. Folliculogenesis, we know, is an important part of ovarian function as it provides oocytes for reproduction. And in the ovary, there is something called as stem cell niche and stem cell nest. So ovarian stem cell nest is one of the major component of stem cell niche, and it is composed of granulosa cell, endothelial cells, immunological relevant cells, and molecules which surrounds the ovarian reproductive cells and regulates their function. This is the typical picture. This is a niche is a key parameter to promote adequate follicular development to restore ovarian function. And we want to regenerate that ovarian niche little bit that is available there. And when we use mesenchymal cells, they have the capacity to differentiate and go for proliferation, self-renewal, and differentiate a different lineage. So that will promote the development of it. Once I said there is homing in the ovary in the damaged area, it will go to develop the follicles. Mainly granulosa cell is important, and its apoptosis is very high in low AMH and POI patients. So here it will inhibit that, differentiate into primordial germ cells, neoangiogenesis will happen, oxidative stress will reduce, and with the immunomodulatory and anti-inflammatory effects, it will give a better outcome. So there is immunomodulatory effect, antifibrotic effect, regulation of angiogenesis, reduction of apoptosis and atresia of the granulosa cell, regulation of pro-apoptotic proteins and promotion of self-proliferation. This is a very important effect that it gives. And the advantages may be marginally increase primordial follicle proof, but definitely improve the function and delay ovarian consenescence. So how you do when you decide the patient, you know which day to take. Normally it is the 8th or 10th day of the cycle when you can visualize the ovary. Whether it is stuck, then you have to go for the, it's not accessible vaginal, then you have to go for laparoscopy. At the same time, what is the volume that you need? So if it's a very small streak ovary, maybe 1.5 ml to 2 ml of the stem cell or PRP, whatever you are using. If it's a volume is good, you can inject up to 3 ml on each side. You have to fix the ovary. You have to just, if it's PRP, activate it just 15 to 20 minutes prior when the patient has been anesthetized. When you are doing the vaginal cleaning, activate it and then immediately go to the ovary and inject it. If the ovaries are very, very small, you can also give an ovulatory agent so that there is a follicle there. You surrounding that you inject, then aspirate the follicle and then again surrounding it. 0.2 to 0.3 ml, maximum 0.4 at one place, and then count 30 seconds very slowly so that it can be dispersed. This is the technique for laparoscopy. Previously, we used to do this. You can see the volume. But when you, and we try to do one puncture only on the hilar side and one on the anti-hilar side laparoscopically. And again, you count 30 seconds so that the leakage, you can see in one previous when we used to do, there used to be some leakage there. But now we are doing this blanching technology. I'll show you what we are following now. That you go inside, just superficially put it and drop by drop. It will take a good amount of time, but drop by drop you put it and don't remove that needle at all. This is an egg retrieval needle till that surface goes blanched. So one is the anti-hilar and the other is the hilar side where you keep injecting and see that it blanches. If you do multiple punctures, whether TVS or whether laparoscopically, what you are injecting can come out again. So that is very important that very slowly there is maximal absorption of whatever stem cells you are putting into the ovary. ISAR Haryana has done a lot of work on stem cells for ovary to increase the reproductive potentials, and they have found 5 pregnancies after 2 after embryo transfer and 3 natural conception. That is the ESCOT study. These are the various studies which I will not go into the detail, but this, don't say that PRP is not useful. Even young patients, the platelets are really good. You can go with PRP also. Older the patient, better is a bone marrow, and very old patients, definitely 40, 45 plus allogenic would be good, but it is not allowed. This patient, 20 years due to religious ban, they could not go for donor egg, but she was referred to me by an endocrinologist for that only. And we decided, she refused donor egg, and we decided ovarian rejuvenation with platelet-rich plasma. She was totally amenorrheic once in a year. Her periods got slightly better every 6 months, 3 months, and then she conceived naturally and delivered a baby. That was platelet-rich plasma instilled transvaginally in the ovary. This patient from UK had 2 failed IVF, both time 2 PNRS. That means the fertilization was not good and it was blamed on the eggs as sperms had no other issue. We did she had heard about ovarian rejuvenation PRP. We did it laparoscopically, and after 4 months in March, we had planned the cycle. She came here 2 days prior, but she was already pregnant that time. She never got her periods and delivered a baby girl. And this is our publication in the Aspire Journal of Fertility and Reproduction, the international journal, The Promising Future of PRP. And we have given our first 45 patients where 27 had positive. 8 were natural pregnancies, 1 IUI and 18 IVF pregnancy where miscarriage rate was 6. So this could be one treatment where any patient who does not have access to stem cells can still think of platelet-rich plasma. Now this lady, 30 years and AMH 0.09, FSH already rising, almost 15. She came laparoscopy, hysteroscopy, and bone marrow derived because the AMH is very low and age is also high. And IUI was done and she delivered a healthy baby. Another, this lady who was already having HPV positive, very obese, 0.49 AMH. In December, we did her ovarian rejuvenation with bone marrow-derived stem cell laparohysteroscopy. She's an American. And in April 2024, she came for IVF. One embryo we had positive and she's pregnant right now. This is a girl from Canada. Her AMH suddenly dropped. She was hypothyroid, obese, 3 failed IUI from 2.8 to 0.25. 2 cycles of IVF plain we tried here, negative. So we counseled her for this. Duostim was done after 4 months. Normally, when you do ovarian rejuvenation, it is better to wait for 3 months. If the patient is of advanced age, you can start in 1 month also. Frozen embryo transfer and a healthy baby delivered. And this patient, in fact, today she was here to show me the baby. 35 years, almost 40, not 39. When we did the IVF, she was 40. 1 ectopic failed IUI 11, 3 IVF cycles failed. And she wanted to do this treatment. She came with, I want ovarian rejuvenation. She is diabetic, she is hypertensive. We did her bone marrow laparohysteromyomectomy and then we did her IVF. In the second IVF cycle, she got positive result and she delivered a healthy baby, which is now 2 months old. She had come today to show me. Is rejuvenating helping people who have unexplained recurrent pregnancy loss with low AMH? Sometimes there is a low AMH and the patient keeps on having miscarriage. There is no other reason. So this lady had 39 years of age, 2 failed IVF, 2 miscarriages, 1 at 2nd month and 7th. She was advised for donor oocytes everywhere, which she did not wanted. So we did ovarian tissue activation, bone marrow derived stem cell laparohysto. She conceived naturally and delivered in November 2022. And a friend from USA came in November to her. She had 0.8 AMH, 46 years of age. This is already in preprint right now. We have submitted the case report. Patient had 4 miscarriages, 1 conceived naturally, and 1 was Down syndrome. All conceived naturally, 1 was Down syndrome in that. Then she tried 1 IUI in USA, failed, 1 IVF where there was no fertilization, and she was advised donor egg. She didn't want donor till she was 48. We did this procedure of laparoscopy, hysteroscopy, bone marrow derived stem cells, ovarian tissue activation, ovarian rejuvenation, and subendometrial PRP. She conceived naturally and delivered a healthy baby boy in July this year. So there is an unpublished data which we have already submitted. It is under review where we are identifying that whether low AMH in cases of unexplained RPL is helping patients. In these patients, is ovarian rejuvenation with stem cells or PRP helping? Totally, we had 52 patients which study we have done, 19 positive, 16 delivered, but 3 had miscarriage, 20 still trying, 8 negative, and 5 have left to follow. Out of these 52 patients, 22 were 35 years or less with low AMH. There, the positive rate was 10, delivery rate high 8, and miscarriage low. And more than 35 years of age, where we naturally expect low AMH, out of 39 positive, 8 delivered, 1 miscarriage, and still 10 are trying. The other had negative outcome. Now I come to endometriosis. It is an inflammatory condition. We understand that stem cell and PRP are going to reduce that inflammatory response. So in endometrium, there is inflammatory response, increased cytokine release, and that affects the fertility by affecting the ovum formation, gamete transport, and even the endometrial development. And recent experiments have proven evidence in both animal and human models that there is promising results of stem cell-based therapy for the restoration of fertility in patients with endometriosis. So this patient had come to us from Himachal. She had regular cycles, but grade 4 endometriosis. She tried 1 IVF cycle in there, and there was low quality oocyte, and she was suggested donor egg. But she came to us for the stem cell therapy. We did the laparoscopic surgery. You can see that the endometriosis was really bad. It was grade 4 kissing ovaries. And because she had already tried an IVF and the quality of oocytes was not good, and she wanted a rejuvenation of the ovaries, we counseled that because we were not very used to doing it in endometriosis patient, which we have started now routinely. After cleaning up all the whatever healthy cortex was remaining, we injected the stem cells in healthy cortex in October 2023. You can see that though there will be little spillage, but everything was done properly. And then for 2 months, we put them on the antioxidants and DHEA. After that, she came in January. We had 5 eggs and all 5 fertilized. We transferred AAB and she delivered a healthy baby girl just this month in October. This is a patient from Delhi, 37 years, married life 1 year. Patient was married for 1 year, 2 miscarriages, and she had an AMH of 0.15 with chronic endometriosis. Same procedure we did, hysteroscopy, subendo, bone marrow rejuvenation, and she conceived naturally and delivered a healthy baby. Even in PCOS patient, there is inflammation because we know that the TH1 response is very high. What we want is TH2 and Treg response higher, TH1 and TH17 we want to reduce. So the human mesenchymal cells can suppress the TH1 response, which could influence the internal inflammatory environment in PCOS. Ovarian function may recover after cessation of autoimmune reaction and the regression of concurrent endocrine disease in accordance with these alterations. So human mesenchymal cells preserve the capacity to suppress TH1 response and the inflammation in PCOS. This PCOS patient from USA, 7.7 AMH and LH-FSH ratio 5.5. Though she had regular cycles, we did a platelet-rich plasma ovarian rejuvenation along with drilling and leprohysteroscopy. She conceived naturally in January 2023. She conceived naturally and delivered a baby in March 2024. So far, we have done so many cases of ovarian rejuvenation with bone marrow derived stem cells. This is an unpublished data. We are collecting the statistics. In vitro activation is a form of therapy of regeneration, though it is not a stem cell. It is said that there are activated primordial follicles and there in the ovarian reserve. So when you try to activate these follicles, it involves the recruitment of primordial follicles into folliculogenesis. They are in a quiescent state, but you need to mechanically activate them. There is a lot of controversy regarding this. One group which started in Denmark not following it. Kawamura group in Japan is still following this, and they have delivered close to 100 babies in 10 years in really bad cases. Here there is disruption of hyposignaling, and you can see this. We have got the training from both the centers, Denmark as well as Japan. You have to see this streak ovary, you only remove the cortex. Medulla, you avoid it, and the cortical pieces, the strip is given to the lab. In the lab, what happens? The embryologist will make as many small pieces, slices. They say 70, 80, 100, even more than that you can make it, and then put it in a vial, and then through the infant feeding tube, we pass it on into the mesenchymal area, into the fallopian tube, where we put it below the fallopian tube, that is heterotopic, or within the ovary, that is the orthotopic. So mesosalpinx is the area we do it and tie it up. And in the ovary, we do it is nowadays what we do, the larger ovary, we take out the cortex from that, make small pieces, and then put it in the ovary, which is of the small size. We don't do any heterotopic, we mostly do orthotopic. This is the lab procedure, which I will not go into the detail how they slice it. There is a special knife which is available for that. And there is a special knife even for the surgery to activate it. And this is Dr. Kawamura, who had been to our clinic for 3 days last September. So this is the first baby of India delivered after drug-free in vitro activation for primary ovarian insufficiency, published in Journal of Human Reproductive Sciences, 0.22 AMH. OTA was, first we started with one ovary only, now we do in both the ovaries also. And first cycle she conceived but miscarried. Then she conceived naturally and the corpus luteum was on the right side where OTA was done. Thin endometrium, Dr. Jyoti has explained very well the definition, the reasons and why it is like that. We know that human endometrium is a functional and the basal layer. Functional layer gets discarded and the basal layer then rebuilds the functional layer. Now, if the endometrium is thin, there is the spiral arterioles with high oxygenated flow, which is detrimental. And this functional layer, the embryo will be away, and that is not going to harm the embryo. Various treatments have been explained, and I'll now go straight to the stem cell therapy. Umbilical cord not allowed in India, but has promising results. But whatever mesenchymal cells, whether from adipose tissue, menstrual blood, or from the bone marrow you use, they can promote the endometrial regeneration by enhancing cell proliferation and reducing fibrosis. It has been shown both in animal as well as human studies. So again, we have these endometrial stem cells which are located in the basal layer. They are the source of progenitor cells that differentiate to form the endometrium. And endogenous progenitor cells that are already there can replace the functional layer because they have a high potential for proliferation, self-renewal, and multilineage differentiation. So here, if you see, this is the basal layer over here. These are the spiral arterioles, and surrounding it, these are the stem cell niches. This is the vessel and surrounding it. So whatever little stem cell is regenerative, this endometrial tissue is remaining surrounding the vessel. That is what we target to replenish, regenerate, and form the endometrium. Because these patients are the patients who have almost very scanty bleed. The endometrium does not go beyond 4 mm, 5 mm. Frequent endometrial fluid is there. So the term stem cell niche was proposed by Schofield. This is a dynamic area, and they have the renewable ability depending on the microenvironment provided by the neighboring cells. So when you improve that, they will start the regeneration. In the treatment of intrauterine arteries, intrauterine adhesion, stem cells have been widely used to reduce fibrosis, repair the damaged endometrium, and improve uterine receptivity. Embryonic stem cells we are not using, but mesenchymal stem cells have good therapeutic effect, and mainly through differentiation, paracrine immunomodulatory effect, and induced differentiation. So transdifferentiation into all these cells, epithelial, endometrial stromal cells, which are important, and vascular endothelial cells. Paracrine effect, what she talked about, exomes and miRNA, and the immunomodulation. The mechanism of therapy is there is the cytokine induction, growth factor production, natural killer cell which are harmful. There are two types of good and bad. The harmful natural killer cell activity reduces, Th17, Th1 decrease, and Treg and Th2 increase. So the endometrial thickness, where after you do the bone marrow therapy, derived stem cell therapy, it increases. You can see the thickness, you can see the thickness. You can instill it by 3 ways. One is simple intrauterine, like you do an IUI. Second is hysteroscopically. Intrauterine will last only for that cycle, probably. Subendometrial hysteroscopic, because you are puncturing the endometrium just beyond and within the myometrium, there are again these niches which can be activated and it can have a long-lasting effect. But directly into the uterine artery spiral arterioles is another technique. So 2 to 8 days before 0.5 ml can be injected in patients of thin endometrium, in patients of repeated endometrial fluid. Maybe you start from day 6, 8, 10, because that is also one therapy for that. And in patients with recurrent implantation failure also you can do that. So, and even with, we have observed that the blood flow, when there is a lot of uterine artery resistance, PI index very high. You do it and then call patients after 2 days, it falls. During hysteroscopy, this is the technique. Again, the same egg retrieval needle you use. After you remove the adhesions, at least 0.7 to 0.8 ml is injected in all the 4 walls, anterior, posterior, and 2 lateral. Again, the same, inject it slowly. Always you do under the ultrasound guidance, so you know exactly where you are going. And drop by drop, put it there. And wait till you feel that, okay, now there will be no leakage. And that is how you have to inject in all the 4 walls. It will increase the quality and thickness of the endometrium. Number of papers have been published of intrauterine and also hysteroscopic autologous therapy. Now what we do at our center is, in the worst cases like tuberculosis, endometriosis, repeated Ashermans due to repeated DNA, fibroids, intramural submucous fibroids removal, septum removal, when the lining is really, really bad and the 2 walls adhere to each other very fast. So here we do it by injecting into the directly uterine artery, going into it, and the spiral arterioles. because we know that in humans, the endometrial stem cell niche is located at the endothelium of the spiral arterioles. There is a study from which I got the inspiration, that is Carlos Simon publication, where he had used only CD133 after mobilizing the stem cells by giving GCSF for 3 days and taking the peripheral blood almost 300 ml 2 to 3 times. Here we directly take the bone marrow stem cells, and then these stem cells are injected in this technique, which I'll show, where there will be transdifferentiation, activation of endogenous and endometrial cells, which can differentiate into stromal, endothelial, epithelial, and all this paracrine factors, immunomodulation, angiogenesis, antifibrosis is also important, and anti-apoptosis, making the endometrium regenerate, improve receptivity and implantation, and restore fertility. We got the ethical approval from our committee. We have the Department of Health Research Certificate, Good Laboratory Practice, and CDSO certificate. And this is the setup where we collect the bone marrow. This is where we prepare it, and this is where the cath lab is there. So this is the cath lab where we use it. And once, what happens when the patient comes admitted for this procedure? We take the blood for platelet-rich plasma, we take the bone marrow, and in the same anesthesia, hysteroscopy is done. All the adhesions are removed. By then, the PRP is ready. And we just inject it in all the 4 walls, and remaining PRP is kept ready for the bone marrow. Once the bone marrow is prepared, which takes about 1 hour to 1 hour 10 minutes, normally 45 minutes in the automated machines, but after that all the checks, etc. About 1 ml to 2 ml. Mainly we get about 15 million mesenchymal cells to be injected on both the sides. So both the femoral arteries are cannulated, and after that, then the patient does not need anesthesia in the cath lab. The patient is awake. One of our team members is always present. And initial first case I'll show you when we used to use the Leach-Wilkinson, but here now we can very well go right into the femoral artery, opposite hypogastric artery. From right side, you go to the left, then you go to the uterine artery and cannulate the uterine artery. Sometimes the endometritis is so severe, the cannulation may not be possible, or sometimes one uterine artery is absent. All this information we get. Once that is done, then the microangiocatheters are introduced, and we confirm it with a fluorescent dilator. They've reached the uterine artery, cannulated, then the stem cells are injected. And then we confirm it. Once the stem cells flow out, we put the dye to confirm that yes, it has gone into the spiral arterioles. You can see that very beautifully it was going. So this is the complete procedure, how we do it. After that, the patient is shifted to the ICU. Sandbags are kept on the femoral artery for 6 hours. And then the patient is shifted to the observation ward, and the next day the patient is discharged. This was the first case report in the world of a bone marrow-derived cell therapy used like this in the clinical and experimental reproductive medicine SERM. And this patient, in 2019 January we started. She had tuberculosis. She was totally amenorrheic, only 1 drop, sometimes brownish discharge. 3 failed IVF, suggested surrogacy, not accepted. So we suggested her this procedure, and she agreed. And we did this. You can see the Leach-Wilkinson and how we identified the internal os and from where the uterine artery. And then her lining developed in 5 months to 7 millimeter, and she delivered a healthy baby. And even now, she has regular menstrual cycle with good menstrual flow. You can immediately assess the patient by asking the number of days, the color of the blood. They may pass small red clots. From brownish, it goes to red. This was a patient from Bangalore who had a frozen embryos there. For 1 year, the embryo transfer was not possible. 1 myomectomy and 1 DNE. We suggested this procedure. And then she started having good, from 2 days menstruation to increase 3 to 4 days, and the endometrial thickness 9 mm. She went back to Bangalore, her embryo transfer was done, and healthy twins were delivered. This patient, 37 years, only brownish discharge. She had severe intrauterine adhesions. Number of all these patients would have undergone 4 to 5 hysteroscopies before they come to us. She had IVF cycle. One was negative and the other was abortion, and history of tuberculosis. So we did 3 hysteroscopy was done before. Then we decided to do the bone marrow derived stem cell therapy in January 2021. She got for the first time, after a long period of time, a regular bleeding. Her lining went up to 7.5. In May, we transferred and she delivered twins. So we prepared a pilot study of 12 patients, which was published, our case series, in the Journal of Regenerative Medicine, where this full therapy was explained. And we also added the cath lab findings, where was the problem, where the uterine artery was negotiable, not negotiable, everything. And out of this, what patients, and we got this, that gestational surrogacy is last option, but before that, this therapy stem cells can help such patients to have their own child when we instill it in the uterine artery through interventional radiology. And to the best of our knowledge, this is the only case series of 10 patients in the world where stem cells have been used like this. So today we have an unpublished data of almost 41 patients where these were the worst cases. As somebody said, hysteroscopy, all medical treatment should be tried. Everything was tried, and when they were last option, they would come to us. 16 positive, 9 delivered, 4 ongoing, 3 miscarriage, and 1 patient is again pregnant after this miscarriage. And 3 did not respond at all, out of which 2 we knew we were not going to respond, but they wanted to do it. 3 lost to follow-up and 22 are still trying. So this is the stem cell lab that we have with the CDSO approval. And this will be my last slide. So I'll just show this. Because there is a designated area, designated rooms that you need, non-classified area, classified area, class 100, class 1000, class 10,000, with a dynamic pass box, static pass box, air showers. Nobody can enter there. It is properly protected. Biometric only is allowed. Media preparation, sterility check, stem cell manufacturing unit, master cell work and working cell bank, hematology. Then there will be even quality control. You can see the machines there. Cryopreservation room. There is a quality control room with all the machines to test everything. So to conclude, I will say stem cells has a pivotal role in reproductive medicine. Ovarian rejuvenation for POI, DOR, PCOS, endometriosis, unexplained RPL with low AMH, and fertilization failure due to low quality oocyte. And also endometriosis and PCOS, which I said. Endometrial niche, which is there in the patients where there is thin endometrium, should be targeted by using the stem cell, especially in severe Asherman's and endometrial atrophy, other end organ atrophy, I would say. But definitely further research, larger trials are required. Molecular basis of the treatment should also be done to find out what exactly and how it is working. But all and all, it is very important to do the proper case selection, proper technology. Otherwise, if we try in each and every patient, even in ovarian part or in endometrium, we may not be getting good results, and unnecessary this treatment will get a bad name. But definitely when you select a proper case with proper technology, it can be hopeful procedure for many patients. Thank you.
Thank you so much, ma'am. I think I'm just spellbounded and speechless to what you are doing and what you showed to us. And I'm so proud to have listened to you with all the therapies. And I think you are the only one, and you are the pioneer of stem cell in the world. And you are doing such a wonderful work. And we are so proud to have you here, ma'am. I just wanted to ask you one question, ma'am. Is there any cutoff for the endometrial lining beyond which you would not prefer to do stem cell therapy?
No, for the intrauterine artery, it will be 2 millimeter. Hardly you can see. There is nothing like that. We can do it because that is, but intrauterine, you do a PRP, then I don't think that if 3 mm or 4 mm is going to improve much. So such
Okay.
patients definitely need stem cells, but PRP is definitely useful when you see 6 to 7. 7 is not to say good enough. 6 is
Right.
also good enough, but the percentage of success goes down. 8
Right.
percentage would be higher. In 5, 6, you get a result, but the success rate will be lower. So their PRP, but stem cells and especially intrauterine is specifically for those who have just very little endometrium that you can see. It is patchy all the time. It is very thin, repeated fluid which comes up inside and it doesn't grow. So their stem cells, intrauterine spiral arterioles is the best outcome. But definitely we have to try all other therapies before we jump onto that.
Okay. So, ma'am, stem cell therapy, do we do subendometrial also or just the spiral artery?
I prefer spiral arterioles and subendometrial hysteroscopy also. That is a patient which is a borderline, where we think that the hysteroscopy adhesions are removed. It's very nicely done. We don't want to do this more invasive procedure. We can do the stem cells into the in hysteroscopically subendometrial PRP. But intrauterine stem cells, I would generally not do because that is for that cycle only. So it's better to do intrauterine PRP. But when it comes to stem cells, it would be better to do hysteroscopically or in the intrauterine arterial spiral arterioles.
Right. So, ma'am, we have a lot of questions here coming from the audiences that, first of all, see, everybody can't, like, it requires a lot of setup for this procedure. So, if we want to refer the patient to you for this thing, for the stem cell, so what will be the cost of the therapy?
Mainly, we will have the cath labs cost, which is coming up, and all the microangio catheters are very, very expensive. So
Right.
what we give them is in the ICU, whatever, because that is within my hospital outsourced, but there the main cost comes up. So you can give a total package with hysteroscopy, subendometrial PRP, what we done, and the stem cell induction into the uterine artery spiral arterioles. It will be about 2 to 2.25
lakhs, right?
lakhs.
And ma'am, how long does it work? If if you have done the spiral arteriole PRP,
You
and
may need to do a repeat hysteroscopy sometime, but I've never done this repeat procedure.
okay,
And the patients who have responded would respond very well in first 3 to 6 months. So that is the time you try to target, though I have done a transfer even after 11 months and got a result.
okay,
But any stem cell therapy, they are saying it is about 16 months is 16 to 18 months. Maybe
okay,
after that a repeat may be needed.
okay. So maximum like within 6 to 1 year, I think will be the
I
best.
would prefer 3 to 6 months. We do
6
one
to
embryo
6.
transfer at least. Yes, 3 months.
Okay, okay, great.
Ma'am, we have one attendee from Pakistan. She is Dr. Saida Bano. And she has asked, actually, she was asking that she had a patient where there is a congenital absence of endometrium as they are sisters and one aunt with normal secondary sex characters, normal uterus and AMH also normal. I couldn't get her question, what she wants to ask us, but
It is
maybe
the
we
absence
can.
of endometrium or uterus.
She's written what seems like a congenital absence of endometrium. I don't know. It must be very thin endometrium. Must not be very, very thin endometrium. It cannot be congenital absence of
Uterus is
endometrium.
there.
But
Huh.
yeah, yeah.
Underdeveloped uterus, basically.
Yes.
Yeah. So there we can do a hysteroscopy, see if there is a patchy endometrium, if it's possible. If she's not responding to estrogen, what she is writing, then definitely this we can try, because endometrial atrophy is the same. They don't respond to estrogen. One is intrauterine adhesions, and second is endometrial atrophy. Whatever amount of estrogen you give, about 20 milligram also, the lining will not develop. You give transdermal, you give transvaginal, or you give oral. So these patients may respond to the intrauterine artery spiral arterioles because the endometrium is only lagging. There is no, but if you go right up to the niche, instill the stem cells, maybe that will regenerate and then start responding to the estrogen that we are giving.
Yeah, ma'am, there's another Dr. Sarita Sukhija. She is, I think, from she is
Nairobi.
Nairobi.
Nairobi. Yeah, Sarita. Yeah.
Yeah. So Sarita is also there. She's asked, how about combining PRP and stem cell injection into ovaries
That is
in
what we do. That's what I
patients
said.
of diminished ovarian reserve? And how are the results?
The results are really good in the best selected cases with proper technology. Stem cells we always mix with PRP. I forgot to mention that paper. There is a beautiful paper which says that to put the stem cells, if you use the PRP base, it becomes more potent. Its amplification of the action is higher. So we always mix the PRP and the stem cells when we are injecting into the cortex. Those patients who have secondary infertility, like if a previous child or a previous miscarriage, those patients who have good volume of the ovary, though AFC may be low, but the volume is still there, and patients without definitely this abnormal genetic marker, they definitely respond very well. Ideal age would be less than 40, but we go up to 45 also.
And ma'am, only doing PRP into the ovaries, will it help, or we have to do
No,
stem
it
cell
will
and
help.
PRP?
That's why I showed PRP, that there are so many clinics doing PRP. If we select the right patient, you remove the karyotyping is not normal, age is this, you see the volume, and you decide young patients with PRP give excellent result unless and until the FSH is very, very high. And AMH is very, very low, like 0.01, 0.02, definitely. But if it's just 0.3, 0.4, FSH less than 10, PRP will definitely help.
And once
Transvaginal
you've
or
done a
laparoscopy.
PRP,
I don't say that you only need laparoscopy. Many patients, when the ovaries are beautifully visible, you can see cortex, you can do transvaginal.
right. So in fact, she's asked whether you do it ultrasound guided or laparoscopy. So in fact, if it is feasibly, if you can easily do it transvaginal with a ultrasound guided oocyte pickup needle, and if you can approach the ovaries that way, do you find any difficulty sometimes identifying the ovaries if they are very small, or sometimes
Yeah.
because the ovaries they are mobile? So how do you fix?
Mobile. That is the reason. That is the reason laparoscopy is better.
Yeah.
Because when it's mobile, it's very difficult. So such patients you counsel, or you are doing laparoscopy for some other reason like adhesiolysis or myomectomy. Because in laparoscopy, there is another technique also, that you just lift the ovary very small beneath the peritoneum, and with a spinal needle and a simple injecting syringe, you go and drop by drop you inject. So that will be a beautiful injection. And the hilum we cannot see in the ultrasound. Hilum we see only on the laparoscopy. So when
Yeah.
there is where the vessels are passing. So the hilar injection is better done under laparoscopy. So stem cells, I'll definitely prefer laparoscopy unless the patient refuses. And PRP, both transvaginal and laparoscopically.
And how much in the gap or interval do you give before stimulating them after you've done a stem cell into the ovaries or PRP?
Younger the age, I would definitely, and male factor normal, both tubes open. I know they can conceive naturally also. I give them minimum 2 to 3 months. And we have seen a lot of patients returning naturally conceiving. Older the age, like they're 43, 44, I would not wait for more than 1 or 2 cycles. And I'll do duostim in such patients immediately, so that we can collect more eggs at the same time. Many a times we are doing ovarian rejuvenation at the time of egg retrieval also. Many people deny it, but there are a lot of Chinese studies also which show that. One paper shows that every month you do it for 3 months, because it is that follicle which has already been recruited which is going to be affected. But it is not so. It is the follicle which is recruited and can come up as a primordial follicle, as a pre-antral and antral, is for ovarian tissue activation, EVA technique, in vitro activation. But PRP and stem cells is for those dormant follicles which are there. So it can have an effect after 4 months, 5 months. So no need to do repeatedly every month. There are many clinics doing every month for 3 months. If you have done a proper thing, one should be enough. Maybe if she has not responded, she wants again after 8 months, 10 months, you can see. Check the FSH level first. The FSH is first to drop. AMH will just marginally rise. So as soon as the FSH start dropping, you can think that, okay, now we can start the stimulation. In 3 months, I generally ask the patient to, wherever they are, to report their FSH and AMH level.
And for the endometrium, if you've done a PRP, when do you do the embryo transfer? Next cycle?
Intrauterine, same cycle.
Same cycle.
Intrauterine PRP, I do even 2 times sometimes. 8th day, if they get recurrent fluid collection, endometrial PRP is excellent for such patients. It will suppress the inflammation. So 2 days prior to embryo transfer. So it could be 8th day, 10th day, 12th day, but not within 2 days. Subendometrial hysteroscopic, I will do even up to 6 months, 8 months, because the results are good, because you have injected just like beneath the endometrium. So there will be a lot of reaction to the redundant endometrium which is there.
Do you combine it with GCSF also, ma'am? Sometimes PRP, or it is only
GCSF I
one
do
of the.
independently. Maybe I have done in one patient GCSF to improve the lining, and then 2 days or 3 days later I do the PRP to improve the lining, more so to improve the receptivity.
Yeah. So I think that was a wonderful talk, and yeah, Dr. Sarita has added one more thing, that she gives clomiphene also, so that she can see some follicles, so that those
Yeah.
small ovaries become visible. And
Yes.
so that is also something that we all do. We give them a little bit of ovulation induction, so that we can at least localize those ovaries with those follicles. Otherwise, sometimes it becomes difficult to identify. So that was great. And I think once this intrauterine into the uterine arteries that the stem cell that you have started putting, and it is doing, I think, magical results. It
Giving
is
good results
bringing.
in very good selected cases. Yes.
Yeah. So it is indeed, it was, I think, a great insight. Though I've heard you, but because I'd heard you, I wanted everybody also to enjoy the same thing and to understand and to imply in their practice. And also those who cannot may kindly send those cases to you. So that was very nice, ma'am. Thank you so much for your time and for your practical knowledge and for your adding to what we all have, and we all know a little bit about it. So thank you so much. And Dr. Laxmi, we can give
Yes.
a
Thank you so much, ma'am. Thank you for your vision. That's very important. I think the vision that you have, that you thought about and then you pursued it, and I think it's doing magical results, what you've got. And we of course would want that everybody should be benefited with it. So ma'am, do you think that heterologous stem cell would come in the market in commercial?
It's already now, the Stempurenics have already got one.
Okay.
It's been passed for limited uses they've given. For
Okay.
osteoarthritis, they've given, I think macular regeneration they've given. So the indications needs to be studied, but
Okay.
already it is in the market, Stempurenics.
Okay. Right. Thank you, ma'am. Thank you so much. Thank you for coming here and enlightening us with your presentation, with your work, and we are so happy to have you. Thank you so much, ma'am.
Thank you, Haryana ISAR Society, for having me over here, Jyoti, Laxmi, and everyone. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. So thank you all the chairpersons who attended, and thank you, Jagsonpal. Thank you. So now we can wind up. Dr. Deepika or Amit,